So skin cancer is the most common skin lesion in the world that happens because primarily of sun exposure. So if in your childhood or in the adolescence or in your work, you're exposed to sun damage, some sunburns or redness in the skin, half an hour can be sufficient to make skin damage. Later in your life, you can develop skin cancer. So some areas that are socially exposed are the face, the neck, the upper part of the chest in the women who wear the V, for the clothing, the dorsum of the hands, the tip of the ears, and of course the bony parts of the face. Skin cancer is more commonly seen in fair skin type, Fitzpatrick 1 and 2, but it is not the only cancer that can happen in the skin because of sun exposure. There are some cancers like melanoma that can happen with no relation to sun exposure because of the palm of the hands and the sole of the foot. They are not sun exposed, but there are melanoma occurring there. And this could happen in black people and color skin people. Everybody has to be aware of that cancer of the skin is very common and it can happen. Okay, so the common risk factors for skin cancer are the color of the skin. In white people and fair skin, or the people who has blonde or red hair, or blue eyes, green eyes. These kind of people are genetically more exposed to sun damage. Why? Because of the melanin is not covering them as the other skin types. The more darker skin are more protected from the most common skin cancers because the 99% of all cancers are related to the sun. And the radiation, the UV radiation and the UVB specifically is the one that is causing the accumulation of the damage in the DNA of these skin cancer cells. Skin cells are always growing from the basal layer, and the skin has a lot of layers, but in the most superficial layer of them, the basal cell type is like the mother of all cells in the skin. And they are receiving all the sun radiation, and they are like trying to buffer it, but in the course of the years, they cannot handle this damage in the DNA, and they start mutating. And if one cell mutates, it begins to spread to another one because they divide and they start making these clones, and they start growing and they form a tumor. The most common skin cancers, which are basal cell carcinoma or squamous cell carcinoma in the skin, they tend not to grow too fast. And that gives us the weapons and the timing for correct diagnosis, correct treatments. But a skin cancer can grow for 5-10 years, and they can form a mass. And if they are not aware of this being a malignant tumor, it can give metastasis, and it can grow into the inside and make more damage than it's seen in the superficial for the eye of the common people, the lay persons. In difference to the melanoma, sometimes can be seen as a mole. But the most of melanomas do not grow from a mole. They grow de novo, like a melanoma, resembling a mole. So this can be very deceiving. That is where the technology from the dermoscopy, digital dermoscopy, and whole body mapping from photo finder helps us in the practice to help differentiate which is a mole, which is a mole with some changes that can be dysplasia, what can be a mole that is not really a mole and can be a melanoma. And this can be challenging, so the technology has helped us in the practice a lot. Not only because of the differentiating of the melanocytic type of tumors, but in the very small skin cancers. We had the opportunity to diagnose and treat a very famous person in my country a couple of months ago. She was coming for a visit because of a mole. Her dermatologist told her to get a biopsy from a mole in her chest. And when we revised the whole body with the technology, we told her, the mole that it's in the chest is not concerning me because it has all the dermoscopy signs of being a nevi, a benign nevi. But what is the story with this thing in your upper lip, And she said, no, forget about it. It's a wart. My dermatologist has been treating it like for the past 5 years with lasers. Let me take a view, okay? So when we did the dermoscopy, it was the most tiniest basal cell carcinoma that I have ever seen.
Wow.
We took a biopsy, it confirmed, and we ended up doing a Mohs surgery. And she's a public face. She performs shows and she has to look well. Her most concern was, am I going to get disfigured from this surgery? And happily, in our skin cancer and melanoma unit, we have the machine from Photo Finder. We have the surgical oncologist who is specialized in dermoscopy and skin cancer. We have the plastic and reconstructive surgeon. We have the pathologist. We have an OR with an anesthesiologist. We have the whole team. That is the whole experience of being treated in a unit, in a specialized unit. This is not a treatment for only a specific dermatologist in the clinic. This is a whole team working to get this person who lives from her face, has to get up on the TV and interviewing every day to be as normal as she can. And she now has 3 months of operated, and she's always doing Instagram stories and selfies. And you can't notice where was the skin cancer. That is the beauty of the machine, and that's working it in our daily routine. To answer your question, I want to tell you a story. Okay, this is like the founding story of why did we embark in doing a specialized unit. Okay, so a few years ago in the pandemic, we had an uncle, a very close friend of my father, who happens to be also a plastic surgeon, and told him, hey, I have fallen in the shower. I have a scar in my face. I want you to try to suture it and make it better. Okay, let's go and see you. And when my father and my brother were examining the patient, he told them, hey, could you look in my armpit? Because I have like a swelling there. When my brother examined him, he told him, this doesn't look great. You have to be checked up by an oncologist. My brother is a surgical oncologist, so I took a check on him. And one of the first questions I made was, have you had a mole been manipulated? Oh, yeah. I have, like 3 years ago, before the pandemic, I had a mole here in the backside of my arm. And they, I think they treated it with a laser. I don't know. Did they send it to pathology? No. They just burn it, and that's it. And now he has a 5-centimeter mass in his armpit. And when I did the biopsy of the matted lymph nodes in the axilla, it was metastatic melanoma. So in the timeline of this patient, he ended up dying within a year because of the aggressiveness of the melanoma. It had been there growing for at least 3 years without treatment. And he ended up dying from lung metastasis. You know, it was a terrible story, and that made us realize that what is happening with skin cancer and melanoma in our country, because we live in a third world country. We don't have a very good health system in the public, and there is a lot of practice in the private setting. So, such as we are a private practice. We don't do a lot of patients because we don't work with insurance. This is real private practice. So the real people who are very interested in getting treated or diagnosed come to us. So we started saying, okay, so let's work in the journey of the patient. What would be the first step? Okay, the first step would be a skin checkup, or a mole checkup. So we established that as a specific consult. So the specific consult with the surgical oncologist. So every time a person tries to, you know, get a checkup or a skin checkup, they end up at least 20 minutes in the clinic with me, naked, from bottom to top, with a manual dermoscopy and with a marker for the skin. So let me show you. This is very important because any skin lesion that I see difference or concerns me with a manual dermoscopy, or that concerns the patient because of it has grown, it is new, it has changed, I mark it. So once we have finished with this triage, we set a standard. Okay, so is this patient a low priority, or is this a high priority? Okay, so if I have concerns that it can be a skin cancer, I mark it as high priority. And he has to go and make the dermoscopic images with photo finder, and we try to solve the case within a week. So if the patient has a low priority, we tend to send it to the typical line. Okay, you can do these photo finder examinations within the next week, and the final report is going to come within the month. And if we have a list that is short, the results are going to come sooner. But because of your low priority, because you don't have any suspicious lesion right now, you can wait a little bit. Okay, so I could say 95% of the patients that come here and the triage resulting in a high priority, we end up operating them for treatment inclusive. Within 3 months, we have done the whole third circle. It's a miracle, because we can't let go a patient who has a suspicious lesion.
Yeah.
First. Then the patient seeing the pictures in the screen saying, wow, is that my skin? Yeah, you can say they can notice that the skin is aged or sun damaged, or the lesion looks very ugly, and they say, I want to get rid of that. Okay, so we say we're going to do a little biopsy, because if this is cancer, we know how to treat it. And we're not going to be scared to take it all right now. We're going to do a little biopsy, we're going to confirm it, and then we're going to make that great plan with surgical oncology and plastic surgery, so we can go into the OR and make the great surgery for maximizing results, not only oncologically safety, but also cosmetically, because the face needs work, the sole of the foot needs work. Maybe sometimes we have to get a sentinel lymph node biopsy. So we have all these steps figured out. and our results are very good. We can do enough when the patients have 3 or 4 stage in melanoma, because they need immunotherapy and they need very high cost medications. But our intentions is prevention, diagnosis, and treating early disease. That is our focus.
Yeah.
So, and that's why Photo Finder has made a huge step for us to shortening this gap, because before Photo Finder, it was a real before, you know, the number of patients that were consulting with us was smaller. The timing from diagnosis to treatment was smaller, because the naked eye doesn't seem to get the great picture of how bad the lesion is. But if you see it in a monitor, that it's it's a huge monitor. I don't know, 24 inches. I don't know. It's a huge monitor. It's a TV practically, and it has the ability to do the zoom, the artificial intelligence, and to measure the lesion, to switch from the lights. And the patient is seeing this, and they are looking like, wow, this is technology that didn't exist a couple of years ago. So forget about the blood tests, forget about the CT scans, forget about the PET scans in the early disease. Really good dermoscopy images are the game changers. I think the success in our skin cancer clinic is because we have embraced the technology. I have heard a lot of colleagues and dermatologists saying, no, but the technology, hey, technology is making this easier. It is not going to replace us. No, we are the ones operating the technology that is making this better for the patient. You have to get your ego aside and say, we are trying to help patients, not trying to help my ego. My ego will show eventually if I go to a congress and I say, I am the one doing this. Okay, that is one thing. But in the day-by-day routine, you're helping patients. And if you happen to embrace the technology to help the patients, they happen to be really, really satisfied and grateful for this. When we do the triage in the clinic, there are some patients who know they are already a candidate for whole body mapping, because maybe they have already the familiar nevus dysplasia syndrome, or maybe they have read a lot about it in the internet, and they say, I have more than 100 moles. I am a candidate for whole body mapping. And we say, okay, sometimes you're right, sometimes you don't, because sometimes the things that you call moles really aren't moles, and they can be a lot of seborrheic keratosis, or they can be solar lentigos, which are that moles. So the triage for us is very useful for separating, the water from the oil, for doing an analysis. And when we ask for them to do this whole body mapping, the first thing they ask is this thing works? And we show research papers, we show examples of patients, we show them photos of how does the machine works, and they say, wow, I want to do this. So the exam can last from 20 to 60 minutes, depending on the amount of moles you have. And in our workflow, we have a technician working the whole day with the machine, and she's analyzing every patient. And in between my consults, I go into the room of the machine. I take a very skimming look through the whole body mapping and through the images, and I say, okay, let me see this one that I have marked with a skin marker previously, or let me show this one that was called in an eye for me. So in that way, I have two times to examine the patients. One with the real patient there sitting with me, and I can repeat the dermoscopy, and a second time when I am in peace with no one around me, and I can look again into every image and analyze it as well. So I have to do for every image, I have to describe the findings, because it would be so much easier if I only say, okay, took the photos and click, and you have the report. Okay, here are the images. The work is not complete until I read all the images. That is why sometimes we have a list of patients waiting for the results. And that's why we, in the triage, assign them as high priority or low priority, because we have to take some time to read them well, because some melanomas can be difficult to diagnose. And we have to look it from this side and again, and that's it. That's how we work.